Good afternoon, everyone. Welcome to this GECHO meeting hosted by the Gastro Foundation in association with Project ECHO at the University of New Mexico. As you may know, these sessions are held every Wednesday afternoon at this time, and the HCC GECHO meetings are held on a monthly basis. We'd like to thank our sponsors, Takeda, Aquino, Amogen, and Equity. This afternoon, we're going to be focusing on certain things to do with diagnosis, specifically the radiological features of Hcc, and also diagnosing cirrhosis. And we're happy to welcome Dr. Giathiga and Dr. Adhiambo, who is a senior radiologist in Kenya, Nairobi, who are going to give the first presentation on the radiological features of Hcc and the LIRAD system. Thanks, that's great. We can see those slides.
Interview. Give me a minute.
Just while we're waiting, just to mention that we have 111 people registered for this meeting from 13 different countries, so quite a good attendance, which we're very happy about. Okay.
Hello everyone, are my slides visible?
Yes, they are.
Okay. So my name is Dr. Giathiga. I'll be taking us through the presentation today, which is about radiological features of hepatocellular carcinoma and features of LIRAD. My facilitator today will be Dr. Adhiambo. So our outline today will be a brief talk about general issues. We will discuss LIRAD definition, when to use it and not use it, and CT and MRI diagnostic algorithms of LIRADs. So during liver imaging, there are key questions that one need to ask themselves. So the first question is there cirrhosis? The second important question that one needs to ask themselves is there cirrhosis? And the third most important question that you need to ask yourself is there cirrhosis? So why is cirrhosis important? Because it determines the differential diagnosis of liver lesions. So in this contrast enhanced image, in this contrast enhanced axial CT scan in the late arterial phase that we see a heterogeneously hypoenhancing lesion in the liver that has rim enhancement. So if this patient does not have cirrhosis, our differential diagnoses are metastasis, hepatocellular adenoma, focal nodular hyperplasia, hemangioma, abscesses, or other lesions. If the patient has a nodular liver surface, as suggested in this CT scan that we can see, we see that the liver surface is nodular and the liver is heterogeneous. A differential diagnosis changes. So first on the list would be hepatocellular carcinoma. You can have regenerative nodules. They could be dysplastic nodules. You could have hemangiomas, abscesses, or intrahepatic cholangiocarcinoma, or a combined hepatocellular carcinoma with a cholangiocarcinoma. So the key point is that cirrhosis stratifies a differential diagnosis. So this is a patient who has a 22 millimeter observation in the liver. We see that it has diffuse arterial phase hyperenhancement. In the portal venous phase, you see that it becomes hypodense, so it has washout. And in a delayed phase, which is 3 minutes, we see an enhancing capsule. So if the patient has cirrhosis or has risk factors for cirrhosis, the differential diagnosis would be hepatocellular carcinoma. However, if the patient has no cirrhosis or has no risk factors for cirrhosis, the differential diagnosis would be an adenoma for connodular hyperplasia, and lower on the list would be hepatocellular carcinoma. So other stratifiers for hepatocellular carcinoma would be the sex of a patient, the age, if the patient has obesity, diabetes, history of alcohol use, current or prior cancer, or pre-cirrhotic liver diseases. So this is an observation where we have diffuse homogeneous enhancement in the arterial phase, as shown by my cursor, but there are areas within the lesion that are hypointense or hypoenhancing. In the portovenous phase, the lesion becomes isodense to the liver parenchyma, which is usually termed as fading. And then in the delayed images at 5 minutes, 10 minutes, we see that the lesions that were, the areas that were initially hypointense enhance, so they start to enhance with delayed imaging. And in a patient with no cirrhosis, the differential diagnosis would be for nodular hyperplasia. So this picture here demonstrates a popcorn, and there's a similarity between the lesion, the focal-nodular hyperplasia in the arterial phase, and a lateral popcorn. So this is a 6 centimeter observation in the liver that has a homogeneous arterial phase hyperenhancement. In the portovenous phase, it equilibrates, becoming isodense to the liver parenchyma. Again, this is known as fading and not washout. So if this patient has cirrhosis, our differentials would be hepatocellular carcinoma or a regenerative nodule. However, this 39-year-old female did not have cirrhosis, so our differentials would be focal-nodular hyperplasia, hepatocellular adenoma, hypervascular, regenerative nodule, amongst others. So this is another series of images. We have a 38-year-old female who has no history of cirrhosis. So in the pre-contrast image, we see an observation that is hypo to isointense in the pre-contrast study. In the arterial phase, we begin to see peripheral nodular discontinuous enhancement that on the delayed phases has centripetal filling in. And this is usually characteristic of a hemangioma. So as radiologists, our reports can be terrible, they can be confusing and non-beneficial to the clinician and even the patient. So some conclusions that are usually given could be indeterminate. We could say sometimes we recommend clinical correlation. Sometimes the report usually reads HCC cannot be excluded, or suspicious, equivocal. Basically, sometimes the reports are usually ambiguous. And if the report is, it is non-actionable. The reports of a non-actionable, the repercussions of an unactionable report are enormous, and this leaves the clinician at a crossroads regarding the management of the patient and also regarding diagnosis and further follow-up of the patient. So as a result of such ambiguous reports, a group of clinicians sat down and formulated a LIRADS lexicon, which was an adaptation from the BIRADS lexicon. So LIRADS means liver imaging reporting, and data system. And it is a comprehensive system for standardizing the terminology, technique, interpretation, reporting, and data collection of liver observations in individuals who are at a high risk for hepatocellular carcinoma. So LIRADS provides a standardized lexicon that has strict diagnostic criteria. It has easy to follow algorithms and reporting guidelines that improve the consistency and clarity of radiologists when they're interpreting and during the reporting. So the process of conceptualizing the LIRAD system began in 2006. So there was an embryonic version of LIRADS that was created by UCSD and TJ people. And then in 2008, the AC LIRADS committee was launched, and the first LIRADS version was released in 2011. So over the years, between 2011 and 2018, there have been several updates and releases of LIRADS that have occurred over the years, and this has led to improved and better diagnosis of hepatocellular carcinoma in patients who are at an increased risk. So LIRAD addresses 5 imaging modalities and 4 contexts that have been shown in this table. So the 5 imaging modalities are ultrasound, we have contrast enhanced ultrasound, we have CT, we have MRI with extracellular agents, and MRI with hepatobiliary agents. The contexts that are used are for screening and surveillance. We have diagnosis, staging, and treatment response. So ultrasound, plain ultrasound without contrast is mainly used for screening and surveillance. Contrast enhanced ultrasound is mainly used for diagnosis. And then the other 3 are used all for diagnosis, staging of the lesion, and assessment of treatment response. So for the purposes of this lecture, we shall discuss the highlighted areas, which is use of CT, MRI with extracellular agents and hepatobiliary agents for mainly diagnosis and staging. So LIRAD's diagnostic algorithm applies only to patients who are at a high risk of HCC. And this includes adults who have cirrhosis of most causes, adults who have chronic hepatitis B viral infection or have current or prior HCC. And this includes adult liver transplant candidates and recipients post-transplant. People who are excluded from the LIRAD's diagnostic algorithm include children or people below 18 years, adults with vascular disorders, and this include vascular disorders that cause cirrhosis such as Budd-Chiari syndrome. You have chronic portal vein occlusion, cardiac congestion, hereditary hemorrhagic telangiectasia, amongst others. Other people are cirrhosis due to congenital hepatic fibrosis or people with pre-cirrhotic liver diseases, unless it's due to chronic hepatitis B virus infection. So this is the diagnostic algorithm that is used. So it has 2 components. So we have the decision tree and the diagnostic table. So the decision tree is used, as we shall see later, when assigning an observation from LIRADS NC all the way to LIRADS M. And then when we get to LIRADS 3, what is used is a diagnostic table, but we shall see that in further detail in the coming slides. So the first thing when using LIRADS is to identify an observation. So lesions, the observation is an observation and not a mass or a lesion. And an observation is a focal abnormality, which is distinct from the background liver parenchyma. So once an observation is identified, the rest of the liver parenchyma is ignored and focus and emphasis is put on the particular observation that you have identified. So in this axial MRI image, we see a liver that is very heterogeneous. However, there's a focal observation that is identified, which further characterization of the lesion of the observation should be done. So once an observation is identified, the next agenda is to characterize the observation. So there are 5 major characterizations that are used. The first is AFI, which stands for arterial phase hyperenhancement. And this usually refers to non-rim arterial enhancement of an observation that is unequivocally greater than the enhancement of the surrounding liver in the arterial phase. So in this image, you can see it's in the arterial phase. We see that there's an observation that has homogeneous arterial phase hyperenhancement. The next characterization is washout, and this refers to a decrease in attenuation of the observation relative to surrounding liver parenchyma. And this is usually seen in the portovenous or delayed phases when using an extracellular contrast agent. So the next image you see the same lesion. In the delayed images, the lesion is hypointense relative to the surrounding liver parenchyma. So this would be termed as non-peripheral washout. The next lesion is a capsule, which is usually an enhancing capsule. So you have a smooth uniform rim of hyperenhancement around most or all of the observation. And this is usually seen with delayed phases. It does not represent a pathologically true capsule. This is seen in this image over here. The next thing you see, or the next characterization is size, observational size. And this is usually the largest dimension of an observation, and this usually should include the capsule. So this is usually clearest, or it should be measured in the phase where the observation is clearest, usually in the portovenous phase. So you measure the largest outer to outer dimension of the lesion of the observation. So the last characterizing, or the last thing that used to characterize an observation is threshold growth. And this refers to 50% increase in size of an observation in less than or equal to 6 months following in the follow-up imaging. So if an observation increases by more than 50% from the previous imaging, that would be termed as threshold growth. So we delve into the Leyrat's decision tree. So of importance when using the diagnostic algorithm is that the observation should be untreated. It should not have pathological, it should not be pathologically proven, and it should be in a patient who is at a high risk for hepatocellular carcinoma. So the first category is Leyrat's non-categorizable, or LR&C. And this usually refers to, it is a category where the image cannot be categorized due to image degradation or omission of certain phases, which may render the study incomplete. So in this image, we see it's a contrast enhanced axial MRI with motion artifact due to respiration. We may see an observation that has arterial phase enhancement. However, it's difficult to characterize the lesion due to the motion artifact. So once the quality and completeness of the study is ascertained, the liver is evaluated for the presence of tumor in vein. So tumor in vein is usually an enhancing soft tissue component within a vein, regardless of an associated parenchymal mass. So in this image, we see an enhancing soft tissue within the main portal vein in the right branch of the portal vein in the arterial phase, which would be suggestive of Leyrat's tumor in vein. So this category is usually of importance because it is a contraindication to liver transplant because it shows likelihood of hematogenous metastasis. The other important thing to note is that once you assign an observation Leyrat's tumor in vein, it's important to highlight the possible etiologies. So for instance, a report should read Leyrat's tumor in vein probably due to hepatocellular carcinoma, or Leirad's tumor in vein due to non-hepatocellular malignancy. So once you see the tumor in vein, if you see any other observation within the liver, include it in the conclusion, but don't give it a Leirad's category. So if there is no tumor in vein, the features of the observation are analyzed to assess if the lesion is definitely benign, which is Leirad's 1, or probably benign, which is Leirad's 2. So the lesions that are included in these two categories include a cyst, a hemangioma, a vascular anomaly, perfusion alterations, hypertrophic pseudomas, confluent hepatic fibrosis, and focal scars. Leirad's 2 lesions also include observations that are less than 20 millimeters, which have no major features that we had seen earlier, or ancillary features favoring malignancy that we will see later. So the next category is Leirad's M, and this usually stands for the lesion is probably or definitely malignant, but it's not specific for hepatocellular carcinoma. So the lesions here would have a targetoid appearance or non-targetoid appearance. So targetoid appearance usually is a rim, arterial phase hyperenhancement, peripheral washout, delayed central enhancement, or targetoid restriction. Non-targetoid mass usually have an infiltrative appearance. They have marked restrictive diffusion restriction, and they have necrosis or ischemia. So these images reflect targetoid appearance that is not HCC. So the first thing you have is rim arterial phase enhancement. You see the lesion in this first image is hypointense, but on the arterial phase, you have a rim arterial phase enhancement. The next thing you have that is targetoid, or is an appearance that is targetoid, is peripheral washout. So a rim arterial phase hyperenhancement, delayed phases, you see that the lesion is has peripheral washout. Another thing that shows that reflects targetoid pathology is delayed central enhancement. So in this series of images, we see an observation that does not enhance in the early arterial phase, but in later phases, there is a central enhancement that is seen, delayed central enhancement that's seen. The other appearance is targetoid transitional phase or hepatobiliary phase, or targetoid restriction as shown in these images. So these are a series of images that have a rim arterial phase hyperenhancement. So all this image demonstrate the same features, rim arterial phase enhancement. However, we can see on biopsy, they showed different pathological diagnoses. The first was a cholangiocarcinoma. There was a combined hepatocellular and cholangiosarcoma, lymphoma, and colon metastasis. So basically what we are saying is that if you find that a lesion is Leirad's M, the next thing that you would need to do is a biopsy to confirm the diagnosis. So if all the above categories are excluded, so from tumor non-categorizable to Leirad's M are excluded, you start to use the diagnostic table. So the diagnostic table usually is employed to assign an observation a Leirad's 3 to 5. So assigning the Leirad's is usually based on the major characteristics that we had seen. So there's the non-rim arterial phase hyperenhancement, there's the observational size, there's the enhancing capsule, non-peripheral washout, and threshold growth. So how you use the table is you first decide has non-rim arterial phase hyperenhancement or not. So once you decide what it has, you measure the lesion. Once you measure the lesion, you count the number of additional major features that it has. So if it has no additional features, you would come to the row where there is none. If it has one, you would align it with none. If it has two or more, you would align it to the last row. So this is an observation that has non-rim arterial phase hyperenhancement. The lesion measures 13 millimeters, so it would fall here. It has no washout, non-peripheral washout. It has no enhancing capsule, and we can't assess the interval or threshold growth. So ideally, this lesion would be a LIRADS 3. So we have an observation that has no arterial phase hyperenhancement. The lesion measures 35 millimeters, so it would fall here. It has non-peripheral washout, and then it has an enhancing capsule. So those are two additional major features. So if you were to align it, it would fall under LIRADS 4. So this is another lesion. So we see it has arterial phase, non-rim arterial phase enhancement. The observation measures 9 millimeters. It has two additional features. So you have non-peripheral washout that is seen here, and also an enhancing capsule. So since these are two major additional features, if you were to align the lesion, it would fall under LIRADS 4. So we have an observation with arterial phase hyperenhancement. Here, we see that it has a non-peripheral washout and it has an enhancing capsule. And the observation measures 18 millimeters. So it has arterial phase hyperenhancement that is non-rim. It is between 10 and 19 millimeters. It has two additional features. So this would be a LIRADS 5 lesion. So we have another observation that has a arterial phase, non-rim arterial phase hyperenhancement. The observation measures greater than 20 millimeters. It has washouts and non-peripheral washout, and it also has an enhancing capsule. So since those are two additional features, that would be a LIRADS 5. So once you assign the LIRADS category, the next step is to apply ancillary features. So these are usually optional and they are used at the radiologist's discretion. So ancillary features can either improve detection, increase confidence, or adjust the category. So when it comes to category adjustment, you can either upgrade the lesion or downgrade the lesion once you apply the ancillary features. So if you have one or more ancillary features favoring malignancy, you can only upgrade the lesion by one category. However, you can only upgrade it up to LIRADS 4, and a LIRADS 4 category cannot be upgraded into a LIRADS 5, regardless of how many ancillary features you have. If you have more than one or more ancillary features that favor a benign lesion, you downgrade the category. And regardless of how many ancillary features you have, benign ancillary features you can only downgrade it by one category. So it's important to note that if you have one or more ancillary features favoring malignancy, and you have one or more ancillary features favoring a benign observation, don't adjust the category. And this is seen here. So if you have even up to 10 ancillary features favoring malignancy and only one ancillary feature that favors a benign lesion, the category that you had assigned before should not be adjusted. So this is a table that shows ancillary features. So they either favor malignancy or a benign lesion. And under malignancy, you can have those that favor hepatocellular in particular and those that are general. So for hepatocellular, you have an enhancing capsule, you have a nodule in nodule appearance, you have mosaic architecture, you can have blood products within the mass or a fat in the mass that is more than the adjacent liver parenchyma. So the next step is usually to apply tiebreakers, and these are usually used if you're uncertain about two categories. So perhaps you have presence of or absence of one or more imaging features that are conflicting. So the category with the lower diagnostic certainty is usually chosen. So if you're not sure whether there's a tumor in vein or no, there's tumor in vein or not, pick no tumor in vein. If you're not sure whether it's LIRADS 5 or LIRADS M, you pick LIRADS M. If you're not sure whether it's LIRADS 4 or LIRADS 3, you pick LIRADS 3. So finally, a checklist is usually done to ensure that the right category has been assigned based on the best clinical judgment. So if as a radiologist, you are certain of the diagnosis that you've made, the categorization it ends there. However, if you're not sure, you reevaluate the lesion, you consult if need arises, and you reassign the LIRADS as need arises. So finally, we have a table that shows the recommendations for management for the various LIRADS lesions. So if you assign a LIRADS non-categorizable lesion observation, the management that is recommended would be repeat or alternative imaging within 3 months. For LIRADS 1 and 2, usually you continue with 6 monthly surveillance. So the patients who are at a high risk of HCC usually undergo 6 monthly surveillance using normal ultrasound. So that is what you continue doing. So if you have a LIRADS 3 category, you repeat imaging within 3 to 6 months, or you do alternative imaging within 3 to 6 months. So for LIRADS 4, 5, tumor in vein, and LIRADS M, a multidisciplinary discussion is usually advised, and biopsy is usually advised for LIRADS M, tumor in vein, and LIRADS 4 lesion observations. So in conclusion, LIRADS is a lexicon for liver lesions used in patients who have an increased risk of hepatocellular carcinoma, and this usually aids in making the radiological reports actionable. And these are a list of well-known people who contributed to the LIRADS lexicon that we have discussed, and they were my references.
Thank you very much, Dr. Gethi. Thank you very much for a fantastic overview of the subject. Before we go to ask if there's any questions, I'd just like to ask Dr. Adiyambo if he has any comments or anything that he'd like to add.
First, to thank Dr. Githaiga for a very brilliant presentation. It's a lot of material. That's almost like 15, 16 years, all compressed into 20 minutes. And yes, and you're able to split it very well in terms of what really prompted the quest to have LIRADS, and also that we borrowed very extensively. If there is any group of professionals, professional radiologists and clinicians who made our work so much more straightforward, I think a lot of the kudos will go to the LIRADS group. And this material is very widely available to us. But what I appreciated the most was how you dissected the LIRADS decision-making tree. That was absolutely brilliant. I don't think I can add anything without really making it more complicated. Thank you.
Thanks very much. Just one question that I have. If you could choose, with regards to characterizing a lesion, would you prefer to use the extracellular contrast agent or the hepatobiliary specific contrast agent? If cost wasn't the issue, which one would you prefer to use?
For most indications, it's going to be extracellular. It's much more appropriate. It's much easier when you look at the major categories. Most of those apply to extracellular contrast agents. when you must use hepatic-specific hepatobiliary contrast media, then you must change the rules. One of the challenges is that the hepatic-specific contrast media is going to cause an increase in the signal within the liver. And therefore, you start to have challenges even in picking up the arterial hyperenhancement. Number two is that when you see this contrast capsular enhancement on a background of a very white or bright liver, it becomes less distinct. So there are areas where the hepatic-specific contrast media has advantages. When you're looking for metastatic disease, when you're looking for leakage, then it has some advantages. Secondly is that it's not very widely available. There are very limited centers in Kenya which use hepatic-specific contrast media. When you need to make a specific distinction, for example, you are caught between focal nodular hyperplasia, completely benign process, and hepatic adenoma, which has the potential for malignant transformation, also torrential hemorrhage, which can eventually kill the patient. Then hepatic-specific contrast media can give you a very confident diagnosis. But in other applications, the extracellular contrast media does a very splendid job. It's also cheaper.
Thanks. Thank you very much. I don't see any other questions on the chat. So I think what we're going to do is let's move on to the next talk. So, one of the challenges you faced when you're dealing with these sort of situations is sometimes making the diagnosis of cirrhosis, and it was emphasized how the the LIRAD system really applies to patients with cirrhosis. So Professor Sonorup is just going to overview how we diagnose patients as having cirrhosis. Thanks, Mark.
Mark, thanks very much. I trust my screen is being seen. It's going to be brief, and I'm probably going to tell nobody on the meeting anything that they don't already know. So it's probably going to be one mass review in the next few minutes. So effectively, just remember that cirrhosis is the end stage or final common sort of histological pathway of a variety of causes of chronic liver disease. And it's characterized in its purest form histologically by these regenerative nodules surrounded by fibrous tissue. Now, on your, I think it's probably your left panel, you're seeing here this sort of normal histology, and try to demarcate where the central vein and portal tracts typically are in the so-called liver acimus. And on your right, in fact, is one of our patients' biopsies a few years ago. This was a patient with alcohol-associated liver disease, and I think you can quite appreciate on this bile serous red stain these beautiful nodules surrounded by these thick folds of fibrous tissue. Just to note, please, and a reminder to everybody, if you're biopsying people to prove the degree of fibrosis, that's absolutely fine. But if you suspect cirrhosis in general, and you're biopsying somebody to try and get a diagnostic idea as to what's going on, you may be disappointed, because cirrhosis tends to be the final common pathway, and all you're left with is just nodules, and the actual pathology may have long gone. In fact, this particular patient had alcohol-associated liver disease, and just on this low power, you can see all the fat and inflammations well left the building already. Elvis has long left the building, so it's not going to help you diagnostically. This is what the normal liver looks like macroscopically. Of course, this is just lovely cuts of an explant of a patient of ours transplanted a few years ago, and you can see that the typical small cirrhotic liver, this particular patient had chronic hepatitis B virus infection with this wonderful collection of macro micronodules. These are the various cuts done on the explant. So in actually diagnosing cirrhosis, remember that I said in its purest form, it's the end stage of a number of chronic injuries to the liver. But really, if you want to call somebody cirrhotic, remember it is actually a histological diagnosis. The problem is you don't always need that, because in the right sort of clinical setting in a patient with chronic liver disease, there are a number of features that highly suggest cirrhosis. And then, in fact, the presence of these clinical features can be augmented by non-invasive testing rather than the gold standard biopsy. So really, I mean, it's a bit of an obvious issue that a patient with a sort of chronic liver disease who has a variceal hemorrhage or ascites or encephalopathy very likely has cirrhosis, and you don't really need a biopsy in that situation. You can probably diagnose cirrhosis fairly easily in the right setting of one of those clinical presentations where typically the physical findings suggest also this enlarged, in fact, caudate lobe, there's a splenomegaly. And remember with alcohol, those typical stigmata that we were all taught at medical school, the stigmata of chronic liver disease. Features like thrombocytopenia and impaired synthetic function also suggest advanced liver disease or cirrhosis. And then, of course, radiologically, as we've just been through the entire LIRAD score, the radiology often supports the presence of a nodular or regular liver, ascites, collaterals, varices, etc. And then really, you don't actually need a biopsy. If there's any doubt, then of course one needs to consider either augmenting your findings with non-invasive testing or in fact liver biopsy, because what you really want to do in your assessment is obviously make an assessment of fibrosis. And often for the surgeon who wants to do a resection of a liver mass, the question is really much of a rule in, rule out, is cirrhosis present or not? But just by way of reminder, if you're using the Metavere score, this is really what Metavere F1 through F4 represents, with F4 being cirrhosis, and then down to F1 being a lower grading of that degree of fibrosis. So how can we evaluate the liver? Well, we can either do a biopsy, which we'll talk about very shortly. We can do serum markers radiologically. I'm not going to talk about today. I think in our setting, the reality of using things like magnetic resonance elastography is a non-starter. It's just too costly and unavailable. And then I'm going to talk about elastography. So when we get down to it, these are the three things we're going to really consider: biopsy, either serum markers, or in fact something like transient elastography. Remember, liver biopsy remains the gold standard, irrespective. Standardly, you want a core of at least more than 2.5 centimeters. You want a minimum of sort of 11 portal tracts for proper diagnosis, particularly if you're doing a diagnostic biopsy. But it's an invasive and it's an expensive intervention. And if you're certainly doing diagnostic reasons on your histopathology, you still require expert histopathologist. It does remain the only investigation that can really accurately assess inflammation and the degree of fibrosis and the pattern of injury. But of course, it's not without errors. I mean, this is a fantastic paper from Massimo Canzani from quite some time ago, showing quite clearly that where your needle lands can in fact determine how much fibrosis you're going to actually read on your core biopsy. You can just see there exactly where that needle track is going to go. So sampling error always needs to be considered. And then, for example, there's also inter-observer, variation between people actually reading that biopsy. Although on the outer edges of minor fibrosis or in fact cirrhosis, the inter-observer variation is far less. It's those intermediate stages where there's in fact variation on inter-observer readings. So what about non-invasive? Let's just jump to serum markers. There are a number of commercial ones on the market, and they really do. The list is as long as my arm, but I want to focus on the two that I think is relevant to sub-Saharan Africa, and that is the so-called APRI score and the FIB-4. The APRI score is really often referred to as the poor man's biopsy. There's the little calculation. By the way, all these calculations are really available on apps on your phone, on MedCalc and other little apps. You can just punch in the AST and the various parameters for the platelets, and you get a reading. And the reality is that there is a range of APRI. Anything above 2 is really in the realm of cirrhosis. And with a FIB-4, there's the calculation. You can punch it into your phone. Similarly, anything sort of above 3.25 suggests cirrhosis. So these little serum biomarker tests, in fact, are very good rule in, rule out. It's those mid-range where they perhaps fall a bit short. So they're quite good at telling you where there's really not advanced fibrosis or where there is cirrhosis. It's the sort of in the middle where it's a problem. Don't forget in our setting that something that's not well reported is that HIV may often confound these readings, particularly if there's HIV co-infection, viral hepatitis, for example, because as you would know, looking after patients with HIV, often slightly lower platelet counts is not an unusual feature, and that is going to overread on your APRI and FIB-4. I just want to mention this because this is something that is clearly emerging in sub-Saharan Africa, is that maybe these cutoffs, I'm not going to go into it, but maybe these cutoffs we're using for APRI and FIB4 may not actually apply within the realm of particularly hepatitis B. And this is data shown from the SONIC B study and also from the study from Professor Haile Michael Desalegn from St. Paul's in Ethiopia, showing that maybe the values we're using for our APRI in sub-Saharan Africa for hepatitis B in fact need to be tightened up quite significantly. So those are just the nuances of APRI and FIB4 one needs to consider. What about transient elastography, the sort of technology we love to play with the last few years? Well, it's elastography. You're really reading liver stiffness. And while a biopsy is, said to be 1/50,000th of the liver, elastography is measuring 1/500th of the liver. So you're reading a much bigger core of liver tissue on elastography. There are confounders you need to be aware of, but it gives you a liver stiffness score that then relates to a range of likely fibrosis. It is an excellent test for rule in, rule out of cirrhosis, if that's all you actually want to know. And even for mid-range reading, those sort of F2, F3, it's also got very high sensitivity and specificity. This is what you kind of get on that little FibroScan machine. This is called an elastogram. And that, of course, then relates to these standardized charts. And that's the one thing one must remember about fibroscanning or elastography, is that you must have an idea of what the likely underlying pathology of the liver is, because you have these standardized charts at which you then read in terms of what the likely fibrosis score is. But it's really well validated for viral hepatitis, becoming increasingly better for MAFLD and for alcohol. And so certainly in the clinical setting, an enormously useful, quick bedside evaluation, real time, of whether there is cirrhosis or not. So finally, just to note that if you're comparing non-invasive, you're comparing sort of serum biomarkers, and you're comparing it with elastography, both have their advantages, disadvantages. I think the advantages of serum biomarkers is that it's got low cost, it's generally easily available, it's well validated, and it probably is not unreasonable for rule in, rule out for cirrhosis. Transient elastography, of course, is far more sensitive, far more accurate, and far better for reading those mid-range levels of fibrosis, such as F2, F3, an excellent rule in, rule out for cirrhosis. Thank you very much, Mark.
Thanks very much, Mark. One of the problems sometimes is for surgeons is to decide if it's safe to do a hepatectomy. And the patients that are difficult to diagnose cirrhosis on are often the ones with very well preserved liver function. So in those patients, how does the degree of fibrosis correlate with the safety of doing a hepatectomy in patients who have very well preserved liver function? Do you think that has a big effect on how safe it is?
I mean, I don't think it's a single value reading. I don't think it's all just about fibrosis. It's about what your likely fibrosis score. And I think that certainly we've been moving towards using elastography a lot more over the last few years to give you some idea as to what the underlying degree of fibrosis is with the greater degree of accuracy. It's also, again, looking at those parameters on the liver profile, INR, and the rest of the liver profile as a more, as a clinical marker of synthetic function. But I think in terms of resection, Mark, we probably entered in the realm here as well as to what the actual hepatic venous wedge pressure is and what the degree of portal hypertension is, and that's got also a bearing on their resectability, and that's a lot more difficult. What I haven't mentioned in the talk, and I wanted to just add it very briefly, but time didn't allow, was that with elastography, something that's grown over the last 2-3 years and has certainly become validated is using spleen stiffness, using elastography, using FibroScan, and measuring spleen stiffness as an indirect measure of portal pressures. And that may be some direction in which we need to move and try to answer the questions more holistically that the surgeon wants answered from a resectability point of view. So I don't think it's, what I'm trying to say is, I don't think it's only a single reading. what you'll see, and there are new kids on the block, so to speak, in terms of technology that could actually help us a lot more, because measuring portal venous pressures is not easy. Obviously, it's quite invasive.
Thanks very much, Mark. Thank you. We're going to move on to a case presentation now. This case is from Namibia. Rashid Nashadengo submitted it. I think Professor Jonas is going to show that, and then Rashid will just represent it. Thanks.
Thank you very much, Mark. Thank you for inviting us to present this case. We're also hoping that with Professor Spearman and also Professor Sonderup will actually, and others can actually maybe give us more insight into this case. Thank you. So the case is that of Mr. E.G. He's a 51-year-old teacher. He's married and he has children, history of smoking or alcohol use, and there's not really relevant family history. He's known with hepatitis B and HIV infection. His hepatitis B DNA PCR has been very well suppressed over many years, since 2014, I believe, on antiretroviral treatment. However, of interest to us is that his hepatitis B E antigen remained persistently elevated despite 2 courses of Pegasus that was given by his physician. His HIV, however, remained very well suppressed over the years. So he had good follow-up with his physician, and the tumor in his liver was first detected in March 2018 there. There were no liver surgeons here then, and he was not really referred to South Africa for any input for a suspected HCC. These are his CT scans when he was referred to us. This is the arterial face, and you can see that there's somehow a lesion there in segment 2, 3 on the left side. It is not really enhancing as you would expect from the HCC. And of interest, his liver on this face also looks very smooth. There was no ascites and there's no enlarged spleen. And then going to the venous face, just going down, you can see clearly that there's a small lesion there. And going further down, you can then appreciate that other lesion, the biggest one measuring about 5 centimeters, and then a small satellite lesion next to it, and another one lower down there, and a small lesion in segment 3. So we thought, with his levels being pretty looking normal and non-cirrhotic, so we thought it's amenable to surgery. And having discussed with him and his physician, so we were also concerned if we were just concerned that there were lots of lesions on the left lateral segment. So we were wondering whether there are other lesions or like a metastatic process going on. So we went on to do an MRI scan, and we couldn't really see any other lesions on the right side of the liver. So most of the lesions were actually confined to the left side of the liver in segment 4A and also in the lateral segment on the left side, So we went on to do a left lateral sectionectomy, and also a wedge resection of the segment 4A. So and the histological results were actually good in a sense that the margins were clear. The closest margin was 4 millimeters, and the smallest segment in segment 4A was measuring about 10 centimeters. And of note, there was lymphovascular infiltration present on the histology. And the normal liver bag showed cirrhosis, although it wasn't really graded, but there was presence of cirrhosis. So we then discharged him back to his physician, and then he was then followed up regularly. And then 8 months after his surgery, his alpha fetoprotein, which was initially low at 7 when we, it was around 140 when we did the operation, and then he came back, it went down, almost cleared. He came back at 8 months post his resection with an alpha fetoprotein of 141. And then this prompted us to do a CT scan. And then this is the CT scan after his surgery, 8 months after his surgery. And you can sort of get an impression on the right side that there's a small lesion, maybe enhancing there in segment 7. Yeah, that one mark, yeah. And then going down, I couldn't really appreciate any further lesions, although you could sort of see there was some enhancing lesion also at the cut margin, although we were informed that the resection margin was clear. So I couldn't really see any other enhancing lesion on this scan. And then going to the venous phase, slowly you can appreciate there's a washout on that segment 7 lesion, yes, that one. And then there's a segment 8 lesion there, so multiple lesions. And then going down again on the cut surface there, you can appreciate there's also some hypodensity there. And then further down, I think, yeah, in the lateral, yeah, segment 6, 7 there. And then further going down, I think there were some others that they were seen. So I sat down with the radiologist and we could actually count about, I think we counted about 4 or 5 lesions. And we're obviously concerned that these are actually signs of metastatic disease. And we agreed with our radiologist that this probably would represent metastatic disease, especially in taking into consideration his AFP that was elevated. So because they were quite scattered throughout the right side, we thought surgery is not really an option. And then we further then went on to do, because we saw that they were mostly on the right side, we went to do a transarterial chemoembolization with microspheres. We did the procedure with one of the vascular surgeons. So we could actually select the right side hepatic artery, and then we use microbeads, and then, yeah. So we actually we will follow him up in 3 months' time, and to see his level of AFP, and also to see, to repeat imaging to see whether there's any further progression, or whether we can actually offer him more transarterial chemoembolizations. So we resorted to do to use microspheres, because in the past we had used coils, and we found that coils actually limits your treatment further on if a patient will still fall within the category of TACE or to conduit TACE. So at the moment we wait and see what happens, and yeah, we welcome more discussion. The fact that his hepatitis B E antigen remained high, did it put him at a higher risk for recurrence, or was anything that maybe we need to do to maybe we could have done to prevent his progression? I'm not too sure. It's just very unfortunate that he has recurrence now. Thank you, Mark.
Thanks very much, Rashida's interesting case. I don't know if anyone has any comments. Mark Sonrop, I don't know if you have anything to say.
Mark, if I may just ask, maybe Dr. Odiambu or Dr. Gitiaga, those lesions in the liver on the follow-up CT scan there, what would be the LIRADs of those? I can just go back to the arterial phase again and just go through it slowly. So we see this one area of hyperdensity. So in other words, it enhances on the arterial phase, and maybe some other small areas. And then the one on the cut surface of the liver, there maybe a little bit of enhancement somewhere over there. But if we go to the venous phase, we see washout in areas where it didn't seem to be enhancement. Would this be a LIRADS 4?
Is a patient at risk for hepatocellular carcinoma?
Yeah, so it's hepatitis B. The patient has got hepatitis B, and on the resection at the first operation, there were also signs of cirrhosis, if I understand correctly, Rashid.
So I might have missed. Is there arterial phase hyperenhancement?
Yeah,
in
so
a discordant area. So it's in a distant area, not the same location.
I can just go back to the arterial phase. I'll just show you. So you see at least one area of arterial enhancement.
Yes.
Over there, maybe. But then on the venous phase, you see more areas of washout than there were arterial enhancement on the arterial phase. So if you look at them, just get them. So for instance, over there at the resection margin, you saw sort of washout. Here you see two areas of washout in segment 7 and probably in segment 8. So those, for instance, that don't have arterial enhancement and you have washout, what would their LIRADS be?
Yeah, so washout carries significance, much more, much more significance than just a capsule formation. So the problem is they're discordant, they're not in the same area. So is it the limitation of the modality? Maybe there are many more lesions. And yes, hepatitis B does qualify for evaluation using the LIRADS, but sometimes you have a limitation with a modality like CT. And sometimes you have to change the modality. If number 2 is that we also don't have a delayed phase here. We have an arterial phase, you have got a portovenous. Is there a delayed study on the same day?
Yeah, we unfortunately don't have a delayed phase.
Because we're looking for more major criteria. We don't have a delayed phase. Okay. Size of the lesion?
I beg your pardon?
Maybe, what's the size? A few millimeters?
Yeah, I guess it's about a centimeter, maybe just sub-centimeter.
Sub-centimeter.
That one there may be a little bit bigger. And you almost see a little bit of rim enhancement there.
Okay, so won't go beyond 4. Won't go beyond 4. Okay.
Yeah.
Yes, so we may want to consider an alternative modality. MR may be much more sensitive as to make the judgment.
Okay. I don't know if there are any other questions, Mark. I can't see any in the chat or any other comments.
I can't see any questions. Mark, Rashid had a question about the E antigen.
Yeah, Mark, Rashid, I mean, very unfortunate patient. He's HIV co-infected.
Yeah.
Just the first issue is that the E antigen status is really not the issue here. Remember that the risk of cirrhosis in HCC, as shown initially in the HPV reveal study, really relates to the viral load. That's what it relates to. And there are 2 takeaway points from that. The one is that the higher the viral load, the greater your risk of progression to cirrhosis, and the greater your risk of HCC. And in this particular patient, he was on antiretroviral therapy. And I think from what you showed, he had a suppressed HPV viral load. The one comment I would have there, and it would be debatable whether it would make a risk, would make a a difference to the risk at all is that I noticed he was on lamivudine and abacavir, and then dual protease inhibitor therapy as part of his antiretroviral therapy, which means he really was only on lamivudine only therapy for his Hep B. He did have a suppressed viral load for his HBV, so obviously it was doing the job, but the standard of care, unless he had renal dysfunction and could not tolerate tenofovir, he would actually have to be on tenofovir, lamivudine, and then his third agent as part of his ART profile. Whether that would make a difference or not, as I said, is a debatable issue. But the actual E antigen status in this patient is really less relevant. The second point is the interesting one as well, is whether this is really metastatic disease, whether this represents de novo multicentric HCC in the patient with chronic HBV infection. Because as you know, these are all childhood-acquired infections in these patients. The HBV was here long before the HIV came, and you've got DNA intercalation into the hepatocyte genome. It's been there for decades. And whether this represents de novo multicentricity or not, or metastatic intrahepatic spread, is an academic discussion, because it doesn't change what needs to be done or can't be done. But it does always raise that particular issue. I think Wendy's on the line. I don't know, Wendy, if there's anything else you wanted to add. But yeah, I mean, those would be my sort of comments on the patient. I don't know why he was on lamivudine only therapy. Maybe it wasn't available, but he should ideally have been on dual anti-HBV therapy as part of his ART.
Yeah, thanks, Professor Sandarup. I was just reading his referral from his physician that he was on TDF, but I think he developed kidney disease at some point.
His creat was 170, I think, Mark.
Chris, I mean, sorry, I missed that. Rashid, probably just to make the point then that as we move forward into the next few years, because it's going to become increasingly more available, certainly across the sub-region, we would be using tenofovir alafenamide in these patients as an alternative to TDF. So these patients would be using the next generation of antiretroviral therapy, which is going to be TAF plus lamivudine plus their third agent, which then gives us that kidney protection effect, hopefully, but still giving them tenofovir.
Thanks, Mark.
Thank you, Prof.
Sorry, Wendy, did you have anything to say?
Yeah, I mean, just a comment that with hepatitis B HIV co-infection, there is an increased risk of having multifocal HCC. So his clinical profile would put him at greater risk of multifocal HCC ab initio. I mean, if we look at the data in terms of prevention of HCC, it does relate obviously to bringing down the DNA level, keeping it suppressed. But the data is better with tenofovir than with lamivudine. So there's better chance of actually preventing hepatitis B associated HCC if you're on tenofovir than with lamivudine. So I think, as Mark says, one should try and have them on dual agents. Also, the question was that he might have had some breakthroughs as well on just lamivudine alone, unless we know that he remained suppressed for most of the time, which would help to enhance the risk of HCC. And then the question is, when he starts on HIV, what is the degree of fibrosis that he already had?
Thanks, Wendy. I just want to make two comments before we start to finish off. The one thing is, there is some evidence now in patients who've had liver resections for HCC who have lymphovascular invasion to use TACE as an adjuvant therapy. It's not something that we've started to do yet, but there is evidence to support that. So the only thing would have been that you would have done your TACE a little bit earlier. The other thing is, I think doing the TACE now is a good treatment option, because it will show you what the biological behavior of this tumor is now. And if down the line there's not massive progression, then you could consider other maybe potentially curative options if he doesn't progress, and that would be maybe local resections, microwave ablation. And if he was in transplant criteria and that was available, that might be an option. So I think the TACE now is a good option to see how things go, and then you can decide if you want to try and take things to the next level or not.
Thank you very much, Mark.
Okay, We still had another 2 cases, both of them from Cape Town, but in the interest of time, we'll let them stand over to our next meeting. So if no more comments, it just remains for me to thank the speakers, Dr. Sitaiga, for an absolutely fantastic lecture on VIRADS, and just to remind you that these sessions are recorded and they're available on the Gastro Foundation website. Also, Dr. Odiambo for his guidance and very valuable comments. Thank you, Professor Sonderup, and then Rashid Nashidengo as well. Also, the ECHO UNM team and ECHO India teams that are always very helpful. And I see that there was a comment that you can please leave comments by clicking a link that is appearing in the chat box right now. And also thanks to the foundation again, Sharon and Karen, to the sponsors. And then just a reminder that next week's meeting will be on patient blood management. And I think Professor Vernon Lowe from Cape Town will lead the discussion. Thank you very much.